Leukemias, here. I bet you this guy is going to have leukemia. It said at the start of the chapter, right? So he's an older guy with fatigue over several months. Is leukemia more common as you get older or less common? It's more common. What's less common is ALL. What's more common? What's the most common cause of leukemia in people? It's CLL, chronic lymphocytic leukemia. Here we have a person who's got fatigue. Fatigue is nonspecific, except we know that that means anemia. The pancytopenia. Well, what's the difference between this and aplastic anemia? What's the difference between this and aplastic anemia? Well, MCV might be up in aplastic anemia. Well, the difference is that, bilobed neutrophils. What does that mean? Reticulocyte count is low means that we have a production problem. Oval cells. Well, this can be looking like B12 and folate deficiency, even though there's no hypersegmentation. Now, the blasts are low, but what tells you it's not B12 and folate deficiency is we tell you that even though there's a hypercellular marrow, there's blasts, and the B12 and folate are normal, no hypersegmentation. This is a rather vague and nonspecific presentation, don't you think? I think so. Bilobed, pancytopenia, old person. High MCV, but there's no reticulocytes. Why is that? Because this is something that wants to become leukemia, but it's not leukemia. This is myelodysplastic syndrome. Myelodysplastic syndrome wants to become acute myelogenous leukemia in the same way a dysplastic polyp wants to become colon cancer, and cervical dysplasia wants to become cervical cancer. And the same way, 99% of cervical dysplasia and low-grade squamous intraepithelial lesions never become cervical cancer. And most dysplastic polyps don't become colon cancer. Most myelodysplasia does not become acute myelogenous leukemia. What's the name of this cell? You see, that's not a band. It's not a band. There's two lobes. A band is one solid section of nucleus. This is two lobes. This bilobed neutrophil is called a Pelger-Hewitt cell, and it's very characteristic of myelodysplasia. You can't say it's myelodysplasia unless there's a small number of blasts and you know that the B12 and folate are excluded. The most important measure of severity is determining how many blasts there are, because the percentage of blasts is going to tell you how close you are to blasting off into acute leukemia. It tells the severity. And your boards are very much into you being able to give prognosis to patients. So you're not going to be the hematology oncology person. You're not going to be the person making the actual chemotherapeutic choices. But you have to be able to be there to give two things: diagnoses, prognosis, and complications. Diagnosis, prognosis, and determine the complications of therapy. So first you're able to tell people and say, listen, I know you have myelodysplasia, but you got 1% blasts. You're going to be okay. You're going to be okay. You're going to be okay. It's going to be okay. The most common cause of death, most people do not go off into acute leukemia or ALL. They don't blast off into leukemia. Most people don't get leukostasis because this is an underproduction problem. Leukostasis is when the white cell count goes above 100,000 and it's 100,000 blasts. That clogs up blood vessels and makes it so that you can't breathe because the lungs are clogged. You can't see because the eyes are clogged. You can't think because the brain is clogged. Leukostasis is so big I can't move through the vessel. And if you take away all the white cells, it's Waldenstrom's macroglobulinemia with an IgM. Since most people don't blast off, what happens is they fade away. They don't convert to lymphoma. There is a thing about leukemia and lymphoma converting. It's called Richter's phenomena, where leukemia can convert into lymphoma convert into leukemia. But that's not what happens here. What happens, it ends not with a bang, but with a whimper, and they fade away with bleeding and infection slowly over time. They bleed because the platelets don't work. And they get infection because even though there's only a small number of blasts, they don't work well. Because a cell, a neutrophil that doesn't have functioning granules, a neutrophil that doesn't have functioning granules is not a good neutrophil. So you get infection. You're mixing the oxidative burst. The initial therapy, the most effective, well, first what you do is what quote-unquote supportive. What does that mean, supportive? You know? Supportive means you're anemic, you get transfused blood. You have low platelets, you occasionally get transfused platelets. You have low white cells, maybe you'll get some GCSF and GCSF and GM-CSF. That's really a hard question because we've always wondered, gee, the white cells are low, but are you going to stimulate the production of more blasts, or are you going to stimulate the production of more normal white cells? But transfusion and treating the infections as you go along. But the other thing is, these drugs, particularly azacitidine, lenalidomide is a TNF inhibitor. Lenalidomide, like we use for myeloma, for myelofibrosis, lenalidomide, for myeloma, for myelofibrosis, and for myelodysplasia, because the TNF inhibitor, it has chemotherapeutic levels of effect. Lenalidomide. Azacitidine and decitabine. Azacitidine actually extends survival. And remember how I said that your boards are not going to ask you to choose, should you do this one or this one or this one or this one? That's not your choice. Your choice is that you know it's not chlorambucil. Your choice is that you know it's not melphalan. And your choice is saying, look, there are medications that can extend your survival. In counseling patients to get a bone marrow, don't you think that's important? It is. That's your question. Now, middle-aged woman who's got a mild elevation in temperature, and she's got some easy bruising. Aha, we're in the leukemia section. I suspect a platelet problem. If we were in the coagulation section, I would say there was a hemoglobinopathy, a coagulopathy, or high PT-PTT. Here, I bet you there's low platelets. She was born in Nagasaki, went to the University of Chernobyl, worked in Bhopal and is a benzene taste tester in a radon detection company. And we've got the classic pancytopenia, all three cell lines. Now, automatically, when you have more than one cell line down, meaning that you have platelets and white cells and red cells and platelets, the only way to really evaluate it is a bone marrow biopsy to evaluate a production problem. You can evaluate red cell problems with other tests. Oh, we have ferritin, iron binding capacity. Oh, we have other things that we can do to look at the red cells, but not with two cells lines down. This person, could this be aplastic anemia, myelodysplasia? I didn't say blast. I didn't say bilobe neutrophils. I did not say blast. I didn't say bilobe neutrophils. I didn't give you any other information. All we know, this is pancytopenia of unclear etiology. And when you have pancytopenia of unclear etiology, the most likely diagnosis is acute leukemia or aplastic anemia. If they want you to know it's acute leukemia, they have to put blasts in there. Ready? Here. What is it? I can't tell you. Is it radiation? Is it benzene and alcohol? Is it HIV? I didn't tell you HIV. That's why it's not HIV. But in this case, just saying pancytopenia, the answer to the most likely diagnosis depends on what they put in your question. And remember, if they want you to know the answer, they have to tell you something. This is a bone marrow aspirate. What test would you do first to confirm the diagnosis? One, you're looking for blasts. These are blasts. One, they're big. One, they're white cells because you see the nuclei. Number two, besides seeing the nuclei in these white cells, the other thing that you notice here is that they're huge. They're huge. And that's why you can get leukostasis with 100,000 of them, because they are so big. The biggest prognostic indicator, you're there to make the diagnosis, give prognosis, and assess complications. Cytogenetics, what do you mean by that? We mean genetic defects. We mean chromosomal analysis tells you how you're going to do. We know that there are certain chromosomal genetic translocations, quadrisomies. There are things that make like 5q deletion. Oh, 5q minus. Well, that's myelodysplasia. It's actually a good prognostic indicator in myelodysplasia, because 5q deletion means there's more drugs you can use. So that cytogenetic anomaly of 5q deletion means we have more to treat you with. Philadelphia chromosome negative CML, the 9-22 translocation, the Philadelphia chromosome, BCR-ABL, it's actually better than Philadelphia chromosome negative CML. And the cytogenetics of leukemias, or how you know, is your leukemia going to get better with chemotherapy alone, or should you go for bone marrow transplant right away? Cytogenetic anomalies will tell you. It will tell you, are you going to do a bone marrow transplant, or are you going to wait to see if they recur? Because recurrent leukemia, do you think recurrent leukemia is easier to control or harder to control? Recurrent is harder to control. The same way if you had an infectious disease. If you had an infectious disease and I told you that you have staph growing on day 4 of vancomycin, why is that staph growing on day 4 of vancomycin? That must be a very resistant organism. Yeah, it's much worse. All trans-retinoic acid. Cis-retinoic acid you put on your acne. Trans-retinoic acid, you add it to chemotherapy for promyelocytic leukemia. M3-DIC, M3-DIC, M3-DIC used to be 90% fatal in 2 months. M3, promyelocytic leukemia, was so fatal that you had to start treating it on the same day as the diagnosis. Now do you understand why this actually is an internal medicine board question? You have to know when to refer this person out to get chemo today. You add this, and the other alternative, you know what you can do? You could use arsenic. Arsenic? Arsenic is good? Well, look, cheese and yogurt are partially rotten milk, aren't they? Rotten milk is a poison. Fermented, nasty milk is a poison. Old milk. But if you ferment it in the right way, what might be a poison is now a pleasure. And in the same way, using things like arsenic and all trans-retinoic acid, you take something that might be a poison, because vitamin A is toxic, causes papilledema. Vitamin A can cause pseudotumor cerebri. Vitamin A, pseudotumor cerebri, papilledema, oh, high opening pressure. Another version. Now, what's the major toxicity of it? This is a hard question. You wouldn't know this. Remember how I said your mission in this? Your mission is to make the diagnosis, give prognosis, and tell people what their adverse effects is going to be. Now, you'll never quite figure this out. So if I didn't know what it was, I would have said liver. It happens to be lung, atrial-lung, but if I didn't know what to do, I would have said liver. Okay, atrial-lung syndrome. Now, when is arsenic? You can't use arsenic, it's a poison. Yeah, well, we got the milk one step before it went rotten, we called it yogurt. Arsenic, you add it to ATRA, all trans-retinoic acid, and it has the effect of near chemotherapy. It has the effect of near bone marrow transplant. Wow, really? I never saw that. That's why you're here studying for the boards. And now, if you relapse after remission, this is when the only thing you can do is bone marrow transplant. Because if you relapsed on chemotherapy, giving them more chemotherapy is not going to help very much. Hey, your bacteria grew while you were on vancomycin and cefazolin. Well, there we have an answer. It's called daptomycin. What if you relapse and continue to grow on daptomycin? So, relapse of leukemia after first remission is like having vancomycin-resistant Staph aureus. You better do something big. And big for the bone marrow means bone marrow transplant. Bone marrow transplant allows you to give levels of chemotherapy that would otherwise be considered deadly and fatal. And you can bump them up and give them levels of chemo that in fact are fatal, but you rescue them. You rescue them with bone marrow. That's why. Bone marrow transplant allows you to give supramaximal levels of chemotherapy and radiation and wipe out the marrow entirely, then repopulate it. But what kind of marrow? Allogeneic, from someone else. Dasatinib, I don't know what it is, but it inhibits something. Dasatinib. Dasatinib is an inhibitor for Philadelphia chromosome positive patients who have ALL. It's a memorizable fact. The most common toxicity of dasatinib is cardiomyopathy. Which of those? Well, if I didn't know what it was, I would have said liver. Let's say liver. Okay, liver's not one of the choices. Kills your lungs? Yes. I saw this just this week. It wasn't on an oncology service. It wasn't detected by the oncologist because the chemotherapy was given as an outpatient the week before. So the person got admitted to the general medical service where they saw me. And the pleural effusion was from their chemotherapy, from the dasatinib. This is a really hard question. Fever, leukocytosis, erythematous plaques, neutrophilic infiltrates. It happens with people with acute myelogenous leukemia, But it's not leukemia. It's not blasts. It's not blasts in the skin. It's not blasts. The smear shows blasts. The blood smear shows blasts, but the biopsy does not show blasts. The biopsy does not show blasts. And so what this is Sweets syndrome. Sweets syndrome is neutrophilic dermatosis in association with acute leukemia. You got a man with left upper quadrant pain, early satiety. He's got early satiety because the spleen. Isn't that a beautiful picture? Let's try it again. Sweets syndrome. It's named after a guy named Sweet. You've got early satiety because your spleen is pressing against the stomach. You got early satiety because your spleen is pressing up against the stomach and lots of white cells. Now, the best initial test is this. Is there blasts in there? Is that lymphocytes? If it's lymphocytes, it could be chronic lymphocytic leukemia. Chronic lymphocytic leukemia could be CLL. If it's neutrophils, normal-looking neutrophils, it could be CML. If it's normal-looking lymphocytes, it's CLL. If there's blasts in it, it's acute leukemia. So the differential tells you, oh, look, if this is all neutrophils, it's chronic myelogenous leukemia. What do you see in a smear on the cell? The smear of the cells in chronic myelogenous leukemia look generally normal. You don't see anything bad on that. The smears and the leukemia and the chronic myelogenous leukemia. What on the CBC that's characteristic? Not on how the cells look. The individual cells are like autism. I can't tell if someone's autistic just by looking at them. Autism has no ultrastructural, no clearly visible abnormalities. But basophils go up. Chronic myelogenous leukemia bumps the basophils, and that's part of the reason people get itchy. It's the itchy and scratchy show. And part of the reason it's the itchy and scratchy show is that the basophils release histamine. The most accurate test of chronic myelogenous leukemia. Bone marrow will show extra production of normal-looking neutrophils. That won't tell you enough. Philadelphia chromosome and its 922 translocation. LAP score is an old test, like TRAP, like tartrate-resistant acid phosphatase, like osmotic fragility, like Schilling's test, like D-xylose testing. No. They're always wrong answers. D-xylose. No, we don't do D-xylose. We don't do D-xylose. We do tissue transglutaminase, anti-gliadin, anti-endomysial antibodies for celiac disease. We don't do Schilling's test. We do intrinsic factor and parietal cell antibodies. We don't do LAP score. LAP score used to be what we did to tell you, do you need a bone marrow biopsy to look for the Philadelphia chromosome? But now we can look for the Philadelphia chromosome with the BCR-ABL with PCR of peripheral blood smear. So we don't need a bone marrow biopsy more. Beta-2 microglobulin is a test of prognosis and severity in myeloma. 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 So BCR-ABL by PCR of the blood smear. LAP, LAP and TRAP are crap. They're old, they're always wrong. See, leukemic cells don't have alkaline phosphatase. Normal neutrophils have alkaline phosphatase. So the LAP score is low in chronic myelogenous leukemia because the LAP score is only a finding of normal neutrophils and therefore is down in chronic myelogenous leukemia. The best initial therapy, very easy, tyrosine kinase inhibitors. Imatinib, dasatinib, imatinib, dasatinib, nilotinib, imatinib, dasatinib, imatinib, dasatinib. Hydroxyurea and busulfan are old therapies. Busulfan is not used for anybody because it causes lung fibrosis. Hydroxyurea is used. Essential thrombocythemia. When is hydroxyurea the answer? Let's work backwards from the answers. You know why we work backwards from the answers? Because there's less answers than there are questions. This question bank, that question bank, the MixApp, Med Study, mine, those other people. I don't like to talk about them because it's like talking about your ex-boyfriend or your ex-husband. Don't tell me about them. So, hydroxyurea. There's less answers than there are questions. Sickle cell disease to prevent crises. Bump up that hemoglobin F. Hydroxyurea, essential thrombocythemia. hydroxyurea, polycythemia vera sometimes to drop the cell count. CML, not used. Interferon used to be used, always wrong for leukemic disorders now. Always wrong. It's passé. It's like the iPod. The following day before you give therapy, the patient has a headache, confusion, and a super high white count. Sludging in my penis, and my penis has malignant hypertension in my penis. Sludging in my brain, I get confusion, headache. Sludging in my lung, sludging in my lung, and I get short of breath. Sludging in my eye, and I get visual disturbance. If there's no white cells and just immunoglobulins, it's Waldenstrom's macroglobulinemia. Here the white cell count is super high, over 100,000. It's leukostasis. Those white cells are huge. Why doesn't this happen in CLL? It doesn't happen in CLL because lymphocytes are smaller. So that's why it doesn't happen in CLL. It is leukocyte sludging, so let's do leukapheresis to get rid of them. And what else do you do? Hydroxyurea is sometimes used here just as a chemical shave. Polycythemia vera, shave down the cells. Hydroxyurea doesn't cure it. Essential thrombocytosis, to shave down the platelets. It doesn't cure it. CML, to bring down neutrophils. If it's super high, shave. It doesn't cure it. Busulfan is the answer when somebody says, I want pulmonary fibrosis. When somebody says, would you make it so I'm short of breath forever and have irreversible fibrotic lung disease? Never for treatment, always for lung fibrosis. 74-year-old man is routinely found on a routine visit to have a high white count, that's all lymphocytes. This is routine to have this found. CD5, that's flow cytometry. Smudge cells are an artifact of slide production. Smudge cells are an artifact of slide production. They're not the way to make a diagnosis. They're actually like a clerical error. It's a defect where you squish the neutrophil. You squish the lymphocytes nucleus. You squished it like stepping on a jelly button. Stepping on a solid, gushy thing, and it squishes out the contents of the nucleus. So smudge cells are not the way to make the diagnosis. We use flow cytometry. This is CLL, a high white count, that's all lymphocytes in an older person. A high white count, that's all lymphocytes in an older person. The therapy for this person, what stage? No thrombocytopenia, no anemia, no big splenia, no lymph nodes. No thrombocytopenia, no anemia, no big splenia, no tritomia. No thrombocytopenia, no anemia, no symptoms, no treatment. No symptoms, no treatment. Melphalan is for myeloma, it's never for CLL anyway. Chlorambucil is like hydroxyurea. It's a chemical shave. Chlorambucil doesn't cure anybody, but we give it sometimes to CLL just to help lower the cell count. Makes us feel better. We rarely, if ever, transplant someone's bone marrow for CLL because they're too old for a bone marrow transplant. How old can you do allogeneic transplants? Allo means the other. Transplant from another. You can do allogeneic transplants up to about age 50. But after 50, what kills you with allogeneic over 50? Over 50, you get killed from rejection and graft versus host. Rejection and graft versus host disease. So you can't do allogeneics old. You can do autologous up to about 70. We do autos for myeloma. Because it's you, baby. There's no rejection. It's you, baby. There's no graft versus host in because it's you, baby. It's you. So 70, allo 50, 70, allo 50, 70, allo 50, 70, allo 50. Fludarabine is a treatment for chronic lymphocytic leukemia. Fludarabine is a component of CLL treatment if it's advanced stage CLL. Spleen, anemia, low platelets. Spleen, stage 3. Anemia, stage 4. Thrombocytopenia, stage 5. 60-year-old man with fever and anemia, Coombs test is negative, big lymph nodes. High white count. All lymphocytes. High white count. All lymphocytes. High white count, all lymphocytes. Guess what? CLL for this guy. Ding, ding, ding. First of all, he's symptomatic. Can't leave people symptomatic. First of all, he's symptomatic. Can't leave people symptomatic. Second, there's anemia. That's stage 3. Low platelets, that's stage 4. Can't leave them untreated. Can't leave them untreated. Can't leave them untreated. Fludarabine is good. Melphalan for myeloma. Chlorambucil is just to bring the cell count down. Doesn't extend anybody's survival. Chlorambucil doesn't extend survival. Chlorambucil doesn't extend survival. Chlorambucil doesn't extend survival. Chlorambucil doesn't extend survival. You can't do an allogeneic transplant at 60. Allo at 50 and auto to 70. Allo to 50 and auto to 70. So the answers to this question, if the answer fludarabine and cyclophosphamide was there, fludarabine and cyclophosphamide were there. If the answer to fludarabine, cyclophosphamide, and rituximab were there, the answer would be fludarabine, cyclophosphamide, rituximab. So you might say to me, hey, fishy, that's supposed to be fludarabine, cyclophosphamide, rituximab. Well, the point of this question is to show you this. Just like life and getting married, the choice that you really wanted as your first choice may not be there for you. So you have to choose the one that's closest to being right, or you'll never get married. Fludarabine, cyclophosphamide, rituximab. It would be rude to ask people like you at your level to choose between, is it fludarabine, cyclophosphamide, fludarabine, rituximab, fludarabine, cyclophosphamide, rituximab. If FCR, fludarabine, cyclophosphamide, rituximab is there, and their CD20 is positive, that's probably the right answer. But you notice how the wrong answers are clearly wrong? He's symptomatic, fatigue. He's got anemia, stage 3. You can't leave him untreated. He's too old for an allogeneic transplant, and chlorambucil just lowers cell counts. And melphalan's for myeloma. You see how the right answer is clearly right? The right answer there is clearly right. I don't want to know. I'm going to skip this question. I don't want to tell you. I don't want you to know. And I don't want you to have to know about big words like bendamustine. From now on, the whole rest of the course is only going to have words with 1, 2, and 3 syllables. Bendamustine has 4 syllables. I'm not telling you. Bendamustine is when you can't get fludarabine, cyclophosphamide, rituximab. Rituximab? You mean like the CHOP rituximab drug? CHOP rituximab drug for non-Hodgkin's? See, what is non-Hodgkin's but a sort of a solid CLL? Non-Hodgkin's is a CLL that if you put it in a centrifuge and got rid of all the serum, the plasma, made it into a ball, slapped it on somebody's neck, that is lymphoma. If you took a lymphoma and cut it off and put it in a blender, made a lymphoma smoothie, and injected it into somebody, that's CLL. Lymphoma is a solid CLL, and CLL is a liquidy lymphoma. And that's why you're using, what's the C in CHOP? Cyclophosphamide. ABVD? So the thing is, it's a lot of overlap with non-Hodgkin's lymphoma. Fludarabine, cyclophosphamide, rituximab, if your CD20 is positive. 55-year-old man, early satiety, big spleen, big spleen, massive abdominal. Oh, look at that, I told you, big spleen. Pancytopenia, and you've got your, dry tap. Tap that marrow. And when you tap that marrow and it's dry, acute leukemia is not dry. AML and ALL are not dry. CLL is not dry, and CLL gives high white count. Chronic leukemias give high white count. Acute leukemias can have low white counts. Acute leukemias can be low white count, high white count, normal white count. Acute leukemia is a low white count in a third, a high white count in a third, and a normal white count in, check me, a third. But pancytopenia, that could be myelofibrosis. Pancytopenia, that could be aplastic anemia, except that we already did. Yeah. Pancytopenia, dry tap, middle-aged person, big spleen. Myelofibrosis on a smear would give you something called teardrop-shaped cells. Do you see the word teardrop-shaped cells here? Myelofibrosis gives teardrop-shaped cells because the red cells squeeze their little heads through the fibers and they get squeezed in the teardrop shapes. I don't see teardrops there. fibrosis would give teardrop shells and would give fibers, reticulin fibers, on the tap, the bone marrow biopsy. I don't see teardrops and I don't see reticulin fibers. The diagnosis is hairy cell leukemia. The most accurate test for hairy cell leukemia, TRAP, tartrate-resistant acid phosphatase, is not as accurate as flow cytometry. Tartrate-resistant acid phosphatase, like leukocyte alkaline phosphatase, are abnormal, but flow cytometry, looking for specific CD receptors, are more accurate. The therapy used to be cladribine, now it's cladribine. Cladribine and pentostatin. Cladribine and pentostatin. Take off the TRAP, it is a crap. Pentostatin is the answer for hairy cell leukemia. Cladribine and pentostatin for hairy cell leukemia. Why wasn't that myelofibrosis? That's pancytopenia and big spleen. Myelofibrosis will give you teardrop-shaped cells, and you'd see fibers. A person with hairy cell, not controlled. Holy shit, what am I going to do? I don't know what to do. I told you to use cladribine. You felt so happy just to get the diagnosis. You're like, you're lucky I even got the diagnosis. How can you ask me the diagnosis, the initial therapy, the follow-up therapy, and now you want me to know what to do in the follow-up therapy? I can't stand this. I'm going to go into family practice. Rituximab. That's the crap for CLL and lymphoma, rheumatoid arthritis, ITP. Methotrexate. Yeah, your cell count is so low, let's give you some methotrexate. It'll kill you, and then you don't have to worry about your cell count. And it'll control your rheumatoid arthritis post-mortem. Chlorambucil is only to bring cell counts down. It's never for low cell counts. CHOP. I don't know, maybe. ABVD, that's for Hodgkin's disease. Adriamycin, bleomycin, vinblastine, dacarbazine. ABVD is initial therapy for Hodgkin's disease. CHOP is initial therapy for non-Hodgkin's. You mean rituximab, which was originally with lymphoma, non-Hodgkin's lymphoma, and rituximab, which we can use for ITP, and rituximab, which we can use for rheumatoid arthritis. Rituximab also gets rituximab, which we can use for cold agglutinin disease and non-Hodgkin's lymphoma, and rituximab with rheumatoid arthritis and ITP is hairy cell leukemia. You bet your chop. You bet your R-chop. Hairy cell leukemia, BRAF mutation. BRAF mutation? What the hell? Oh, I heard of that. BRAF mutation, or BRAF. Yeah, I saw somebody yesterday. So, do you listen to Trex? What's Trex? T-Rex? Yeah, Trex. Okay. My name is C-Rad. No, it's Conrad. B-Rad. I've heard of that. That is, what is that? Melanoma. Hairy cell leukemia can get, but that's the same. You mean it's the same inhibitor for whether it's hairy cell or melanoma? Squish, smush, splash, stepped on my jelly donut, squeezed my pakora. Smudge cells, 30,000 white cells in the old guy. That's all normal appearing lymphocytes. Normal appearing lymphocytes. Smudge cells is a laboratory artifact. Okay, first of all, is he symptomatic? No. Next. Is there anemia? No. 37% is not anemia. Next. Is there low platelets? No. 176,000 platelets. Next. It's not low platelets, stage 4. It's not anemia, stage 3. Not big splenia, stage 2. Not even big lymph nodes, stage 1. This is stage 0 CLL. Stage 0 CLL. Stage 0 CLL. Chlorambucil is just to bring cell counts down. Fludarabine is when you're symptomatic. Prednisone is part of lymphoma leukemia treatment. Bone marrow transplant because we want him to go from being asymptomatic to being asymptomatic. Stage 0 CLL with smudge cells gets no therapy. Stage 0 CLL with no smudge, with smudge cells. Excuse me, whether smudge cells or not doesn't matter. Recurrent streptococcal, the smudge cells were irrelevant. That was the point about that. Streptococcal infection, white count is 30,000. This is, we're in the CLL section. We're in the CLL section. Well, the problem about CLL is that the CLL lymphocytes, in terms of their function, why is it a disease? See, when we say that there's a high white count with no lymph nodes, no big spleen, no lymph nodes, stage 1, no big spleen, no anemia, stage 3, no thrombocytopenia, that's why it's called stage 0. High white count alone without symptoms is not really a disease. I wouldn't like it either. But the same way, if you found out that I had Helicobacter pylori, you don't need to give me a PPI and 2 antibiotics. If you found that I was Epstein-Barr seropositive, you don't need to give me CHOP. If you found that I had papillomavirus on my head, you wouldn't need to do conization of my head because a lot of people just have papillomavirus. We live with it. Like the same way even nice girls have E. coli in their stool. You don't have to treat it. But you're treating this person because they've got infections, and the problem about the lymphocytes in CLL is either they make wrong antibody, meaning they were damaging antibodies that are going to cause hemolysis and low platelets, damage normal tissue, or they don't make antibodies and you get infection. So when you don't make antibodies and you get infection, it's hypogammaglobulinemia, and we give you some intravenous immunoglobulins. We inject intravenous immunoglobulins. And if you make antibodies against normal tissues like your platelets and your red cells, we give you steroids. Patient with CLL, see stage 2 palpable spleen, anemia, stage 3. What are you going to do about this anemia? That's stage 3. Stage 3. What are you going to do about that anemia? Stage 3. Well, I got 2 answers for you. First of all, the treatment for serious CLL is not there, which is fludarabine, cyclophosphamide, rituximab, fludarabine, cyclophosphamide, rituximab. But even if fludarabine, cyclophosphamide, rituximab, FCR was there, you still would say prednisone, because how do you know this is autoimmune hemolysis, not stage 3? See, this is the point. CLL stage 3 can also be CLL with antibodies against red cells. How do you know? The answer is because the reticulocyte count is high. If this was stage 3 CLL, the lymphocytes would be displacing the rest of the marrow. You wouldn't be making reticulocytes because it would be a production problem. The high reticulocytes, because reticulocytes should normally be 1 to 2%, 1 to 2%, 1 to 2%, 1 to 2%. The reticulocytes are high, meaning it's a destruction problem, it's autoimmune hemolysis, and that's why we give steroids. Oh, no, please. Don't make me learn numbers. No, don't make me learn numbers! CLLs don't have translocations. Okay, I don't have to memorize any. ALLs, maybe. CMLs, I have only the Philadelphia chromosome, I hope. Hairy cell. Shit, you're lucky I understood the BRAF mutation. Vemurafenib. BRAF mutation. Vemurafenib. BRAF mutation. It's like the melanoma, BRAF melanoma, BRAF melanoma, BRAF atrial. Okay, which is it? I'm not even going to be on here. I don't want you to look at me when you have to learn this. Yep, it's M3 acute promyelocytic leukemia. 17p deletion. Okay? Ocrelizumab. Those are CD20 drugs. Ocrelizumab, ofatumumab. Sounds like a Nigerian name. Calling me Ofa. Like the chief resident I have. Idelalisib, Elemtuzumab. You're killing me. Ibrutinib. Ibrutinib inhibits Bruton's tyrosine kinase. Venetoclax, I made up. There's no such drug. Okay, no, I did. I didn't make it up. Ibrutinib and venetoclax are used in exactly this in 17p deletion CLL. That's what they're for. So look, ladies and gentlemen, I'm very careful with how many of these drugs I tell you. But all of these are CLL drugs. Alemtuzumab, I tell you about because alemtuzumab is good not only just for relapsed CLL, alemtuzumab is also good for aplastic anemia. Ocrelizumab and ofatumumab are CD20 drugs that's in the same class of rituximab, and I tell them to you because not only are they good for CLL, they're also, some of them are good for multiple sclerosis. And these two drugs, that's what they do. They work on 17p deletions. So I have a suggestion for you, and I hate to seem corny here, but we're in an age of being able to do really miraculous things, have specific guided therapy. They're only going to target damaged cells with specific genetic mutations. And we have to know about them because they don't affect the other cells. They leave the normal tissue alone. It's like caspofungin, mycofungin, and the other fungin, anadulafungin, Caspofungin, mycofungin, anadulafungin. I was in the hemonc part of my brain. They only affect the fungus because we don't have a 1,3-glucan. Amphotericin is like CHOP. It kills the fungus, it kills you too. But caspofungin, mycofungin, and anadulafungin, those are echinocanins. They only affect the fungus. They leave the rest of the tissue alone. That's the way of the world, being specific. 17p deletion, and they work only on the 17p deletion cells. If you could see it as I see it, which is, look around, how lucky we are to be alive right now. History is happening in our board exam. Look around, how lucky we are to be alive right now. History is happening in your exam.